Good morning, everyone. Welcome to the Singapore Cancer Society Lung Cancer Awareness Webinar. I'm Ivy Lim, and your moderator for this morning. Before we start, let me do a quick introduction for Singapore Cancer Society. I'm a volunteer with the Singapore Cancer Society. Singapore Cancer Society is a social service agency with the mission to minimize cancer and maximize lives through its programs. So some of the programs include public education, screening, patient care services, and to needy cancer patients, hospice home care, financial assistance such as cancer treatment subsidy, and rehabilitation support program. At the end of today's webinar, there will be a Q&A session, so do post your questions. As you can see at the bottom of the screen, the Q&A, give us your questions. Before you do that, just to have a quick look, today I think we have over 700 people who signed up. I was just wondering how many of you are actually returning, joining us today, that you have been to our sessions before. If you are returning, please type a 1. And if you are new to this webinar, give us a 0. So we have an indication how many of you are our old friends and we are meeting new people. And welcome. You can also watch this at Facebook, and then also be putting in your questions in the Facebook section. And we'll try to answer as many questions as possible. If you are unable to answer any of the questions, we will pick up 20 most commonly asked questions and post it to our No Cancer to Beat Cancer microsite. So today we have two doctors with us who will be sharing on the common and hidden signs of lung cancer and what you need to know about the prevention, detection, and treatment in lung cancer. We will also like to inform everyone that Dr. Jen's segment, or rather, will be delivered by Dr. Vaish instead, and we, because of some uncertainties in his schedule. We will also invite you to also fill up the feedback form at the end of the session. So I am an ex-smoker. So I smoked for I started since I was 16, sorry. And I quit smoking at 2002. So it's been 20 years now. I've stopped smoking. I'll ask this question later, is that if I'm a reform or renew ex-smoker, does it make any difference to my health and things like that? So without further ado, let us talk to Dr. Muthu, an associate consultant for medical oncology from the Tan Tock Seng Hospital, to share with us on the common lung cancer symptoms such as coughs and why does it not go away. Does the 100 days cough, is that a myth, is that real, or is this only applicable to certain ethnic groups? So over to you, Dr. Muthu.
Yeah, good morning, everybody, and thanks, Ivy, for that fantastic introduction. So hello, I'm Dr. Vaish. I'm from Tan Tock Seng Hospital. I'm a medical oncologist. And this morning, we'll just go through about cough and cough surrounding lung cancer and what should we know about it. So first of all, we should talk about what is lung cancer. And so what cancer is in general is a malignant growth. And in terms of lung cancer, it's when our healthy lung tissue actually develops a mutation. So as you can see in the picture, there's the pink part of the lungs are actually the healthy portions. And when one of the cells actually develops a mutation, for any reason, it actually then has an increased tendency to grow and invade into the tissue surrounding it. And when that happens, it can grow slowly to become a tumor. The tumor is the white spot that you can see in the picture. And in certain circumstances, the tumor can then continue to grow and spread outside the lung to other organs and to other parts of the body that some of us know as the word metastasis. So just to recap, we always have been told that the top cancers in Singapore for men is colorectal cancer and for women is breast cancer. And we know we have been told many times about colorectal cancer screening, breast cancer screening for mammograms. But if you see for the second cancer in men and the third most common cancer in women is actually lung. And if you see the top 10 causes of cancer death is unfortunately number 1 for lung for men and lung is number 2 for women. So it tells us that it's actually a condition we should really be aware of. So what are the myths about lung cancer? So myths are that only smokers get it. But the unfortunate truth is that about 20% of lung cancer cases these days are actually diagnosed in never smokers or those with a low smoking history. And this is getting more common because the amount of smoking is actually dropping, something similar to Ivy herself. People who used to smoke, many people are more aware now, so people are actually smoking less. The next myth is that smoking is the only risk factor for lung cancer. The truth is that there are other risk factors, including environmental exposures, previous radiation therapy to the chest, and some people who have long-term and chronic lung diseases. The other myth is that some people say, I have smoked for years, so there's no point stopping now. And the truth is that studies have shown that smokers who stop after their lung cancer diagnosis actually have better outcomes compared to those who do not. And then what are the other myths? That lung cancer, when you're diagnosed with it, this definitely means it's a terminal diagnosis that isn't very long left. Thankfully, lung cancer we know can be cured if we find it in the early stages. And furthermore, because we have recent advances with cancer medicine detection, patients with advanced lung cancer may actually have better outcomes than the patients from many, many years ago. Next myth is that antioxidant supplements protect against lung cancer. Unfortunately, the truth is that we currently don't have any robust clinical studies to actually support this. And another myth is that lung cancer usually comes with symptoms. And the unfortunate truth again is that this is not always the case, and symptoms can occur at any stage.
So are there any common symptoms, signs, for lung cancer, and what are they? Because a lot of times I hear when they detected, they are at a very final stage,
Yeah. So I think that's a fantastic question. So common symptoms that we should know about is a cough. And I mean, most of us get a cough. COVID's been around the last 2.5, 3 years. So we think that, cough can even last a few months after COVID or any normal flu infection. But sometimes you worry why your cough is actually persistent. So it's a long-standing cough, and it can be a dry cough, or it can also be a productive cough that may have some blood mixed with the sputum, and sometimes it's just dry blood that is stale, so it looks like kind of rust-colored as well. Another one is actually chest pain, and it may be on the left side, the right side, the front, or the back, and it can be often worse when you have deep breathing or when you cough, because sometimes the tumor can grow slightly outwards and touch the lining of the lung and affect the nerves. Yeah. The other thing that you actually see in many cancers is that we can have loss of appetite and unexplained weight loss, which you should see a doctor to get it worked up. And finally, if cancer spreads, we can also see shortness of breath. Other common symptoms are lethargy, where people can feel weak for no good explained reason, and hoarseness of voice when the cancer actually touches on the nerves that supply the voice box in our throat, and also infections such as bronchitis or pneumonia that just do not go away or keep coming back. And finally, if you don't have asthma, you don't have a lung condition, but you suddenly get a wheeze, and the wheeze just doesn't go away. So this can be another symptom that people actually develop. Yeah.
So with all these signs and, what are the common signs then, to show that this has spread? Because I met somebody at the radiology department, and she said, I actually have lung cancer and it has become now brain cancer. So, how does it work in terms of the complex symptoms, which is harder to spot?
Yes, yeah, so that's the unfortunate scenario when cancer actually has spread. And so when symptoms that occur, and sometimes signs as well, so we can have aches in our joints, in our back or our hips, sometimes in the neck as well, when the cancer actually spreads to the bones. In the case of your friend where, cancer actually spread to the brain, sometimes there can be nervous system changes, such as a headache, they may feel giddy, sometimes there may be numbness on like one arm or one leg, and sometimes balance problems. Yes, and if it's spread quite far, or even if there's a large spread in one side of the brain, there sometimes can be seizures as well. Also, if it spreads to the liver, there can be yellowing of the skin or the eyes. I've put up the picture of 2 eyes here just for us to actually see the difference. If you can see the picture on the right, it's actually an eye with actually the whites of the eye are very clear. The other picture, which is the one closer to the words on the left, you can see it's actually some yellowing of the eyes, and it's very subtle and you may not actually notice it. But this can actually happen when cancer spreads from the lung to the liver and actually cause a buildup of bile in the liver, which we know as jaundice. And then another thing would also be swelling of the lymph nodes, which we know are basically immune cells all over the body. Lymph nodes are normal, healthy part of the body, and they are supposed to clear infections, clear dirt, and they're part of our immune system. When they clear out cancer, it actually starts to grow, and they become these small rubbery balls in the sides of our neck or in the above our collarbone as well. Then there are complex symptoms. These need to be diagnosed by a doctor. You don't need to memorize any of this, but this is just good for you to know since you're attending a lung cancer talk this Saturday morning. But for example, there's Horner syndrome. If you can see the picture on the right, it shows that there's actually a drooping of the eyelid on one side, and that same side you actually have a lack of sweating, and the pupil actually doesn't dilate when the doctor shines a light in the eye. It's very subtle sometimes and it's hard to pick up, but it's usually because the tumor is pressing on a special type of nerve called a sympathetic nerve. Another kind of syndrome we see is when a tumor is growing on the right side of the lung and it compresses on a very big vessel. If we all know about the jugular vein actually drains into an even larger vein which is closer to the heart. And when a tumor presses on this vein, what sometimes can occur is that there is a backlog of blood that goes up to the neck, causing a bluish red skin color because the venous blood doesn't drain into the chest. Not to worry, this doesn't happen as often as it may seem, and it is something that usually doctors can pick up quite quickly if you visit your GP or even the A&E, and someone will be able to diagnose it quite quickly. Don't wait when you actually see symptoms like this. This is a very busy slide, but what I'm just going to say briefly is that cancer can also produce hormone-like substances. Natural hormones are actually made in our body, things like calcium and this hormone called antidiuretic hormone, things like the steroid hormone, which we know as cortisol. And finally, there are other hormones that actually affect our brain, our lungs, our heart. And these kind of hormones, when they are created by lung cancer cells, they can actually cause an excess of the hormone levels in the body, causing you to have different symptoms. For example, if you have a lot of steroid production by the lung cancer cells, you can actually have weight gain, you can have weakness, drowsiness, and fluid retention. It's like largely because cancer cells are actually once upon a time healthy cells that were part of your body. So what occurs is that when they mutate and become what we call bad cells, they actually have a tendency to create the hormones that the natural body can create. But the body actually is able to regulate and balance the hormones. Cancer is unable to regulate hormones, and that's why sometimes this can happen. Thankfully, this is not as common, but it's just something that is good to know. Yeah.
So quick coming back to the hormone situation, is that suddenly that the eyelid will droop?
Okay, so yeah, that's not, something can happen suddenly if the tumor is very aggressive and it spreads and it touches the nerves quite quickly. But in many cases, it may actually happen slowly over the course of months or even years, depending on the type of cancer. And in those certain circumstances, it may actually be very subtle. And your friends or family may not notice because they've been seeing you every day or every week at work or at home. And so when your eyelid just starts drooping slowly, or you yourself feel that one side of the face is not sweating, or the one where I showed where there is a bit of blockage of the blood vessels, you may not feel it so immediately because it is happening over a course of time. So your body is able to sort of compensate for that, and that's why sometimes it's actually lung cancer is diagnosed late for that reason.
So in these situations when they actually have a drooping, because people think this is an aging process, right? But when they go to see a doctor, I would assume that the doctor would be able to pick it up and immediately with a chest x-ray, that will be, a warrant further investigations.
Yeah, so absolutely. When you actually have any of the symptoms, the complex symptoms that I actually discussed, those will actually usually be able to be picked up on a simple x-ray that can be done at your GP or the polyclinic, and usually they will then send you quickly to the A&E or to the specialist like me or Dr. Tan in the hospital.
So coming back to it is that there is also an increased group of people who are non-smoker but they actually have lung cancer. So if a person does not smoke, and would their lung cancer symptoms be the same?
Okay, yeah. So that's actually the big question. What about never smokers? So if we have never smoked, can we actually get any and all of these signs and symptoms? All of the above symptoms can actually occur in any of us if we develop lung cancer, but this really depends on where the cancer starts, where it spreads to and such. It can happen in never smokers, ex-smokers, and second-hand smokers. Now, if we just focus on the graph on the right side, what it shows is that lung cancer risks in never smokers smokers and those who have stopped smoking actually varies by a lot. So the red line, which is the largest and biggest line, is actually people who continue to smoke cigarettes actively for the rest of their life. And the smallest line right at the bottom, which is the blue dotted line, is people who are lifelong non-smokers, or what sometimes doctors call never smokers. So these people actually, as you can see, have a significant difference in their risk. And the lines in between actually show people who have stopped smoking at different points of time in their life. And you can see the earlier that you have stopped smoking, the lower the chance of getting cancer. And in fact, if you see someone who stopped smoking at 30 or 40, their risk is far closer to the people who have never been smokers than people who are continuing to smoke. So it's actually really good news that you stopped smoking more than 20 years ago, Ivy.
Yes.
Yeah.
Thank you. Thank you very much. And what can we do to reduce the risk of lung cancer?
Okay, so preventive measures in general to reduce overall cancer risk. For lung cancer in particular, please stop smoking if you're smoking. And if you are a person who is actually part of a passive smoking environment, please try to avoid it as much as possible. There is data to show, clinical data to show that if you have a passive smoking environment where you are a second-hand smoker, meaning you don't smoke, but someone around you smokes quite a lot, then you should try to ask them to either step out when they do their smoking, or you remove yourself from that kind of environment. Because your risk of lung cancer is higher than someone who's never smoked, even though you may not be smoking yourself. And of course, a healthy lifestyle, this actually would be important for all cancers. So this would include exercise, which includes cardio and weight training, a balanced diet, reduced alcohol intake, and of course, as we know, don't overeat. In terms of lung cancer screening, there's actually no universal screening for lung cancer in Singapore. For certain people with heavy smoking histories, there are some lung cancer studies that have shown that they may benefit from certain kinds of scans, but please do approach either a lung specialist or a lung cancer specialist to actually advise you on that.
Would you say that for some smokers, you would encourage them maybe every 5 years to get a chest X-ray?
So yeah, that's a great question, which comes to my last point on the slide. Basically, if you're an active smoker, what I would recommend is that first of all, cut down your smoking or stop if possible. Cut down slowly and stop. And usually you may actually need the help of a doctor to do that. You may need nicotine patches or nicotine gums to do that. But secondly is to actually see a pulmonologist, also known as a respiratory physician in the hospital. They may actually know the guidelines on how to actually follow up on this. We don't have very definitive guidelines for lung cancer screening in Singapore because the data is still up and coming, but we do know that in certain groups of patients with certain smoking history for certain periods of time, they may actually benefit from certain types of CT scans, and this can only be done in the hospital setting. So do get either a referral to if you're very interested, getting a screening done or stopping your smoking, please do actually see a specialist in the hospital. But you can start with your GP just for the simple thing of stopping your smoking, and you can have some sort of medical support with nicotine gums and patches and the such. And there's right ways to actually do that also, because immediately stopping smoking can also cause you a lot of phlegm and respiratory symptoms and a lot of withdrawal. So you may need help to get through that as well.
So I started smoking at 16, and then when I quit, that was like 20 years ago. I think it was about 30 years old. And the weight gain wasn't because I stopped smoking. No, on the contrary, no. So don't worry about that. I didn't have to go through patches or whatsoever. It was strictly because I find that I was paying too much tax, on top of income tax. I have to pay for cigarette tax, and which is a lot. When I was still smoking, 26 or 6.90, and I realized that I was paying almost $5 of cigarette tax. And I said, no, I'm not paying cigarette tax anymore. And then I finished the last packet and I said, that's it,
Okay.
Do I miss it? I don't. I'm glad I quit because it's something that I don't necessarily need to do that. So I also have a lot of friends who said that maybe we should just continue to smoke since, we are with friends who are smoking. The air is cleaner that way. But, we all know that that's not really the way to go about. Thank you, Dr. Muthu, very much for the insightful sharing. And next up, we are inviting Dr. Wei Chong, our Associate Consultant from the Medical Oncology Division of Medical Oncology from the National Cancer Centre Singapore, NCC, and to share with us on the prevention, detection, and also the treatments of lung cancer. And welcome to you, Dr. Tan. Could you give us an overview, what lung cancer is? in oncology perspective?
Yes, of course. Thank you very much, Ivy. My name is Wei Chong, and I'm from the National Cancer Centre of Singapore. So, as part of this talk today, I'll be covering a few things. So, we'll be going through the types of lung cancer, what treatment we typically give for lung cancer, as well as a little bit about screening, which Vaish has very kindly already gone into a little bit just now. What are the different types of lung cancer? Basically, traditionally, we tend to divide lung cancer into two big categories. We call them non-small cell as well as the small cell lung cancer. So nothing too complex about that. And this classification has been around for the last 20, 30 years. We do it this way because it is important for us to determine the treatment, because the treatments for these two different kinds of lung cancers are vastly different. However, in recent times, particularly in the last 10 to 15 years, we have increasingly discovered that non-small cell lung cancers and the divisions into the various subtypes of non-small cell lung cancers are just as important in terms of determining treatment. So under non-small cell lung cancers, we have the most common being adenocarcinoma. You may hear doctors talk about this, followed by squamous cell carcinomas, which are typically, although not exclusively, associated with cigarette smoking, as well as large cell carcinomas, and smattering of other rarer subtypes of lung cancer.
So, what can you tell us about the non-small cell lung cancer, and also tell us the different stages and how do we treat them?
Yes, that's a very good question. So, basically, we would all know that cancer is generally divided into 4 stages. This is true whether for breast cancer, colon cancer, or many different types of cancers actually adopt this system of staging. So non-small cell lung cancer is no exception. Is staged from 1 to 4, and the staging is a complex process, but broadly speaking, it's usually based on how big the tumor is, whether it's spread to the lymph nodes and which lymph nodes it has spread to, as well as whether there's the presence of any spread to other organs. So for example, the liver, the brain, or the bones, which we have heard a little bit about from Dr. Vaish previously, which can give rise to different symptoms. And this is very important because, I always tell my patients, stage determines treatment. Treatment is different for the different stages of lung cancer. And of course, we do know that the higher the stage, the poorer the outcomes as well. On the right there, you can see a graph of the 5-year survival of lung cancer based on what stage it is diagnosed at. We can see that towards a higher stage, in the stage 4s, they do a lot less well than patients who are diagnosed in stage 1 and 2. In short, late detection of lung cancer actually leads to higher mortality or death from lung cancer. We have not done very well with lung cancer in the last 10 years or so because our screening programs for lung cancer have not really come that much to the forefront, although we are trying. Unfortunately, most lung cancers today are still diagnosed in the late stage, either the stage 3 or the stage 4 setting. More than half lung cancers are diagnosed in the late stage, where there are still very effective treatments available, but it does result in significantly compromised outcomes. So as you can see there, we typically divide lung cancer into the early stage, which is usually stage 1 and 2, locally advanced, which is stage 3, and metastatic, which is stage 4, and a variety of different treatment options for each of these different stages. Broadly speaking, stage 1 and 2, early stage lung cancer, surgical resection or going for operation is the standard of care. In cancer, we always say if you can take it out and cure it, you should do it, right? So, but oftentimes we often forget that while surgery is the mainstay of treatment, it may often be followed up by so-called post-operative treatment or what we term as adjuvant treatment. So this may come in the form of some chemotherapy or targeted therapy or immunotherapy, which helps to reduce the risk of recurrence of lung cancer after the surgery. Because all cancer, whatever you do with it, has a chance of recurrence. And in the early stage, it's often up to us to lower the risk of recurrence as much as possible, even after the patient has done surgery. Now, some patients may not be fit for surgery because lung surgery, after all, it's rather extensive. It's a major surgery. Some patients may be a little bit older. Some patients may have medical problems which prevent them from doing surgery. And radiation is sometimes used to treat very early stage lung cancers when surgery is not an option. Now, moving on to stage 3, what we term as locally advanced. Unfortunately for stage 3, there's no one best treatment per se. It is often a combination of different treatments put together to try to cure this cancer. It is still curable. This depends on the size and location of the tumor, the extent of spread to the lymph nodes, where the cancer is spread to in terms of the lymph nodes. And it generally includes some combination of either radiation, chemotherapy, or surgery in some combination or another. Now, additional treatments may sometimes be suitable in selected situations, and this is something that's often determined by an oncologist. Sometimes we may give immunotherapy, sometimes we may give targeted therapy, but these are so-called adjunctive therapies for stage 3. Now, unfortunately, many lung cancers are diagnosed in stage 4, and this usually means that it's metastatic or it's spread outside the organ of origin, which is the lung. In these cases, unfortunately, treatment is not curable, although it's still a very treatable disease. The treatment is often aimed at extending a patient's life, improving their quality of life, preventing the cancer from spreading further, growing further, and causing problems down the road. And in this space is where most of the developments in lung cancer treatment in the last 10 years have been. We are increasingly moving to the realm of what we term as personalized treatment. The different treatment approaches are needed depending on the characteristics of cancer. We now know that there's many different subtypes of lung cancer beyond the usual non-small cell and the small cell lung cancers, and we use that to our advantage in terms of targeting the treatments to lung cancer. And this often comes in the form of molecular profiling. So we often send cancers or tumor biopsies for extensive testing to see whether there's any mutations that we can target with specific treatments.
I'm assuming that we are talking about immunology therapy in this instance when you're talking about targeting it, right? Because, molecular profiling. So, what can you share more about that?
Yes, of course. So, immunotherapy is just one aspect of it in terms of this move towards personalized treatment. I would term many of the advances that we have made over the last 10 years as targeted therapy. So, targeted therapy brings to fore the concept of using a certain medicine or drug based on certain specific changes in the cancer, which we are now able to detect very effectively with modern day testing. And these changes come in the form of mutation. So I think Dr. Vaish has very briefly mentioned this previously. When a normal cell develops into cancer, it is often due to a mutation, a change in the DNA of the cell. And there are many different types of changes which can lead to cancer. And what usually happens is that a certain change leads to a change in the growth signal, and the cancer cell is stimulated to grow uncontrollably, and thus resulting in a tumor. So what targeted therapy actually does is that the medicine or the drug blocks this signal, blocks this growth signal, causing the cancer cells to be starved of this growth signal and to die, simply speaking. And over the last 10 years, we have found that identifying the right target, the right mutation, and therefore giving the right treatment actually goes a long way in terms of improving a patient's survival. So this is a very important part of lung cancer treatment. So you can see there, this is a pie chart denoting what we're seeing in lung cancer in the year 2020, and this was published by in the Asian setting in particular. And we can see there that there's many different types of mutations in lung cancer. And in our population, one of the most common ones is this termed as EGFR. You may or may not have heard it. This is a breakthrough in the last 10 to 12 years in lung cancer. And you can see in Asian setting especially, up to half of patients actually have this mutation. And each of these different mutations entails a certain targeted treatment for it. So if we find one of these, we can use one of these treatments, and many of these treatments are actually in the form of tablets, which makes it a lot easier for patients as well. And in particular, we know that EGFR mutation is the most common subtype in Asia. You can see there in typically Caucasian populations, such as in Europe, in America, we find EGFR maybe in about 10 to 20% of patients. But you can see here in Asia, we have in excess of between 40 to 60% in many countries of patients with EGFR. In Singapore in particular, based on our local studies, up to 60% of patients actually carry this mutation, for which there are very effective oral treatments available. And what are these treatments? They come in various forms. Currently, there's many different tablets on the market available. We may or may not have heard of things like Iressa, Tarceva, Visimpro, Gelotrif, and the most recent one, Tagrisso, with osimertinib, that many of us have started using as well. These are medicines targeted against EGFR. Now, some common side effects, it's generally well tolerated, the medications, but it can result in some side effects, namely things like rashes, diarrhea, some nail infections, as well as oral ulcers. Something that's really quite a lot better than conventional chemotherapy, I must say. Yeah.
So the EGFR, I'm assuming you are using EGFR when it's already stage 2 and above?
So there are specific indications for using EGFR drugs. Typically, we use them more for stage 4, in the stage 4 setting, when we are unable to cure the disease, but these drugs have made waves in terms of being able to control the disease for prolonged periods of time, at minimal side effects to the patient. And that's very important, and that's a big breakthrough from previously. Now, the EGFR targeted treatments have moved towards earlier stages as well. Most recently, there have been advancements in using these drugs in what's so-called the adjuvant or the post-operative setting after surgery, but that is something still in the process of development, and I would suggest that that's something that you probably should discuss with your doctor. Yeah.
What about immunotherapy?
Yeah, that's right. So immunotherapy is, I guess, the new kid on the block, even newer than targeted therapy, right? So basically, it's a treatment that uses a patient's own immune system to fight the cancer. A very novel concept, apart from traditional chemo, which directly kills the cancer. This one doesn't. This one activates your body to kill the cancer. And the ones that we use currently are termed as checkpoint inhibitors. They basically activate the patient's own immune system by targeting proteins that traditionally prevent the immune system from recognizing the cancer cells and killing them. And these drugs basically, they remove that checkpoint, or they remove that blockade, which is why we term them as so-called checkpoint inhibitors. And basically, it leads to an increased ability of your body's immune system to recognize cancer and kill it, right? Now, immunotherapy will likely be part of the treatment of patients without suitable mutations for other targeted therapies like EGFR. We have incorporated it into standard treatment for lung cancer in the stage 4 setting especially, and it is now a very important part of the treatment regime in lung cancer patients. That's not to say that it does not have side effects. It does. Again, it's generally more well tolerated than chemotherapy. However, immunotherapy, as with many different kinds of cancer treatment, does have potential side effects. It can affect some organs in the body. For example, the hormonal organs. It can cause thyroid issues. It can sometimes cause lung inflammation. Uncommon, but it does happen. Liver inflammation, intestinal inflammation, as well as sometimes rash as well.
So I do host many of the public awareness program of cancer. And I think small cell cancer or small cell lung cancer is probably the first time I heard of small cell. So does it mean the rest of the cancer is large cell? Can you tell us a little bit more about this small cell lung cancer?
Sure. Yeah, so typically we divide them into small cell and non-small cell, a very kind of broad classification. Anything that does not look like small cell is non-small cell. And as we have seen previously, non-small cell has many different types, many different mutations that we can target. Now, small cell is a very specific type of lung cancer that we have known about for years. And it is probably the lung cancer that's most commonly associated with smoking. It is unfortunately a very aggressive form of lung cancer, and typically patients don't do very well with this lung cancer. It accounts for about 15% of lung cancers, and as I've said, smoking is the major risk factor. We typically divide small cell lung cancers into what we term as limited stage and extensive stage. So we don't often use the stage 1 to 4 we use for most other cancers because that's just not very useful in terms of determining the treatment. But suffice to say that a limited stage small cell lung cancer is limited to one side of the chest. We usually treat it with chemotherapy together with radiotherapy, whereas for extensive stage, because it's spread to the rest of the body often, and we cannot do radiotherapy, at least not effectively, we often just use a combination of chemotherapy and often immunotherapy as well. So the treatment, as you can see, is very different from a non-small cell treatment, which is why we term it as such.
Can people live with only one lung?
The short answer is yes. It does depend on how good your lungs are. We do know that surgery is one of the treatment options for lung cancer. So that entails taking out at least a part of the lung. In rare cases, sometimes surgeons may opt to take out the entire lung if the tumor is too big, for example. It often depends on how good your other lung is. So this is all the more important. So, if you smoke, smoking does entail a certain degree of damage to the lungs over the years. It makes your lungs less healthy and it makes your lungs function less well. And often the problem we find is that for patients who have smoked over a long period of time, they may not have enough lung reserves to tolerate a surgery or even radiotherapy, which does have a certain likelihood of damaging the lungs. So that's a problem. Yeah.
Would it be more tough to treat when you have to remove one lung, the resection remove one lung, with only one left with one lung per se? And I think the treatment itself would be a little bit more careful because the person only has one more lung to tolerate all the treatments.
Absolutely, absolutely. So we don't often do this. I must say up front, we don't often do what we term as a pneumonectomy or removal of an entire side of the lung. Surgeons would often tell you that it entails a significantly higher risk, both in the operation as well as after the operation. And the risk of patients developing problems after removing an entire lung is very high. So we tend to avoid it as much as possible. But if we need to do it, if we really need to do it, we are often very careful about it. We will not advise for it if we think that the patient is unable to survive well with just one lung, and that usually that usually comes in the form of whether the other lung has had damage over the years, how the other lung is functioning, and we would often, of course, be very careful about administering additional treatments on top of the surgery. And one very important thing would be radiotherapy, because radiotherapy, as I said previously, does have the propensity to damage lung tissue as well. So we would often be very careful about administering radiotherapy, especially to a patient who has already one lung, and that is something that we'll be very careful about.
I'm not sure the next question actually relates to Dr. Muthu or yourself. Is this: have we now have new devices? I mean, if you have pacemaker to help your heart to beat, right? Have we actually have something developed to become an artificial lung already?
Yeah, artificial lungs. I mean, that would be the dream, isn't it? But unfortunately,
no, it's fine.
Yeah, I don't think
Not
so.
Not yet. So quit smoking. Maybe
Yes,
that's another
absolutely,
message. So the next question is: there any screening options in Singapore for lung cancer?
Yes. So I'm glad you asked that. So I think screening is fast becoming a big thing, especially in lung cancer. And like Dr. Vaish has said previously, screening is not something that's very well defined in Singapore, especially for lung cancer. There are no definite guidelines for screening. The reason is because it's very simple. If you think about it, the screening studies were all developed in Caucasian populations. And in Caucasian populations, most of lung cancer is related to smoking. 80%, 90% easily related to smoking. In Singapore, we have up to 40-50% of lung cancers that are not related to smoking. So we don't know how to screen for this group. It's very difficult. Suffice to say that MOH has taken kind of a stance on this. So for some people who have a heavy or long smoking history, screening does indeed have a role. It may be considered if all of the following are fulfilled. So you are between 55 to 74 years old, you have smoked an amount equal to at least 1 pack a day for 30 years, what we term as 30 pack years. and you are still currently smoking, or you have only quit smoking in the past 15 years. So past 15 years, actually the risk of lung cancer associated with smoking is significantly decreased. So these studies do not account for that. MOH, I'll say up front, has designated lung cancer smoking under lung cancer screening under category 2, which means to say this is MOH way of saying that lung cancer screening is not for everybody. It's not like mammogram, it's not like colonoscopy, but it is only for select individuals with high risk. So in this case, smoking. It's done using a low-dose CT scan, which often needs to be done in a hospital or healthcare setting. It can detect lung cancer early, but the drawback is that we do get false positive results. So just because you find something on the scan doesn't mean it's cancer. It may be other things. It may be an infection. It could be an infection. It could be, something else altogether. And the problem is that if you find something, then we do need to check it out, because what if it is cancer, right? And the role of screening for never smokers is an area of ongoing research. Now, to that end, I think we do have a collaboration with SCS, or we call this study the Solstice study, that we are putting forward in an effort to understand the impact of lung cancer screening in our population. Now, it is important to do this study, as I said, because lung cancer screening is not well defined in Singapore, and we're trying to find a group of patients who are between 55 to 74 years old, and who do have some risk factors for developing lung cancer, and in so doing, we hope to see if a screening is beneficial. So if this is something that you're interested in, and if you fit the criteria, do talk to your doctor about it if you're interested.
Thank you very much, Dr. Tan. Thank you.
Yeah.
We now open the floor. If you have any questions, you can put it into the Zoom Q&A box, or if you're watching us from Facebook, you can also put it in the comment. We'll collate the questions. Gee, I look huge, man. Never mind. The quick question I have is this: do we see a younger population with lung cancer these days?
Okay, I can take that question. So yeah, we do actually see people getting lung cancers younger and younger. We don't have a huge data to explain why this is happening, but this is actually unfortunately the case over multiple cancers actually, be it breast cancer or even colon cancer. These are the top 3 cancers as I showed earlier. Now, we suspect it's probably a combination of the environment, the kind of food we eat, the overall exposures in our nature and nurture. So there's a combination of many things, but the exact answers are still somewhat up in the air, unfortunately. So that's the reason why I think if we have screening guidelines, which we do for at least 3 or 4 cancers in Singapore, we should follow those guidelines quite closely, particularly for the breast and the colon, cervical cancer and such. But in terms of lung, I would say that we are seeing patients younger and younger, but the reason is a bit unclear at this point. Yeah.
So follow-up questions is, primary cancer is lung cancer, and are they smokers?
So you mean that
the younger group that you have seen, younger lung cancer patients, did they only have lung cancer, or is a result from other cancers?
So it's a combination of multiple things. Sometimes these people, most of the time, it's actually a primary cancer.
Primary cancer.
But in certain cases, a small group, you can actually see they may have had childhood cancer, such as lymphomas or leukemias that required radiation when they were young. And this puts them at risk of certain cancers in the future, such as lung, such as breast, because they may have had radiation to the chest when they were young for lymphoma or leukemia or some other bone cancer and such, which are common childhood cancers. So that can put them at risk of cancers 20, 30 years down the road as well. Yeah.
Okay. So the hot potato question, COVID. If I have COVID and I had twice COVID, for example, do I actually increase my risk of lung cancer?
I don't know if Dr. Tan wants to take that.
Yeah, so that's been always the question on everyone's mind, isn't it? So, I think the short answer is that there's no evidence currently that COVID or I'm going to throw a bone out here, COVID vaccination increases the risk of cancer in any way, whether it be lung cancer, breast cancer, or the like. Many times, what leads us, to this so-called inevitable conclusion is, patients may have had COVID, and then, 2 months later we discover cancer. in some form or another. And the natural conclusion would be to say that, hey, did COVID lead to this cancer? Now, it is. I'll be very cautious about drawing that conclusion. No, is it COVID that led to this cancer, or is it because you had COVID? You visited a doctor, and whom you would never have visited otherwise, right? And the doctor did a thorough checkup, and maybe suspected something, right? And also I'll be very careful in drawing that conclusion. I guess the short answer is there's no conclusive evidence, so I'll advise against drawing such conclusions on these by ourselves until more evidence comes to light. Currently, there isn't any suggestion of that.
And also, it takes years to become cancer, isn't it?
It takes years. So different cancers behave differently, right? So some cancers have a very well established so-called pre-cancer phase. So breast cancer is one good example, which is why screening works in breast cancer so well. You do mammograms, every 2 years, and if you're lucky, you detect it in the pre-cancer phase. You do surgery, take it out, and that's the end of it. For lung cancer, it may not be so well defined, I would say. Yes, I think there's suggestions that there may be so-called precancerous lesions in lung cancer, but we don't often see that. And maybe that's why it's been difficult to pin lung cancer down with screening. And to say that cancer develops over certain years, yes, certain cancers, of course, take years to develop, but the more aggressive cancer, so for example, small cell lung cancer, which I've said that's very aggressive, often it's so aggressive that it develops over the course of a few months. Now, this is unfortunate. I have patients coming to me and asking me, I feel very well even up to 3-4 months ago. Why is it suddenly I've got stage 4 cancer, small cell? My answer is that unfortunately this is a very aggressive cancer and can often grow over the course of just a few months. You may not have had a cancer even up to 6 months, 1 year ago. So it's very variable, unfortunately.
I see.
Yeah.
Okay. So rapid fire, quick questions. People with tuberculosis, TB,
Yep.
would they be higher chance of getting lung cancer?
So depending on the complications that develop from TB, if you actually get scarring in the lungs that cause recurrent infections, that may potentially cause it. But not that I'm aware there's been any direct link to a treated TB that, many Singaporeans actually have had TB. It's quite endemic in our country. So no, not that I'm aware that there's any direct link for TB and lung cancer, no.
Asthmatic people with long-term asthmatic care, with steroids and things like that, would they also be higher chance?
So again, asthma is not directly linked to lung cancer unless it's poorly controlled asthma that leads to a bad lung condition like chronic lung diseases. There's actually poorly controlled asthma that leads to things like bronchiectasis and scarring of the lungs, which in the long term sometimes could lead to lung cancer. But usually such patients are on routine follow-up with actually a pulmonologist in the hospital. They actually have routine scans. Mm-hmm. So and they usually have an infectious disease doctor following them up as well. So sometimes they're actually picked up quite early. Yeah.
Secondhand smoke, it used to be the big topic, right? Secondhand smoker are worse, higher at risk, secondhand smokers. And then of course, then they talk about the ashtray symptoms where the house becomes like an ashtray, where the smells and everything linger, that becomes the third hand smoke, right? And they say, it's even higher risk than being a smoker yourself. So do you see a lot more patients which are actually secondary smoker?
Yeah, so passive smoking I think is an interesting point. We do know for a fact that passive smoking definitely increases the risk of lung cancer more than those patients who have never never smoked before. Whether or not it actually increases the risk past a chronic smoker, a person who smokes, that is a bit debatable. Passive smoking, I think, is a bigger thing in Asian settings. In the Asian settings rather than more in the Caucasian populations. We do find many of our Asian lung cancer patients who come to us. Many of them don't have a direct smoking history, but when you dig a little bit deeper, they do have some exposure to passive smoking. So it is certainly a risk factor, I think. But whether or not it really increases the risk past that of chronic smokers, of course, it kind of depends also on when you talk about chronic smokers, how much they actually smoke. Many of these patients who smoke over a long period of time, their exposure to cigarette smoke is a lot more than what a passive smoker typically gets. So I think their risk is generally still rather much higher. Yeah.
Okay. Viping. People always think that, oh, I'm not disturbing everybody else. It's just me and my little gadget, and of course, any take on this?
First of all, I don't think vaping is legal in Singapore yet, right?
But there's still people doing that.
Yes, so put that out there first. But if you are vaping or you're vaping overseas, whichever, vaping has no direct link yet because it's still a relatively newer phenomenon. So I don't think there's any huge studies that have linked vaping directly to lung cancer. But I could imagine that because vaping actually, there are studies showing that there are significant side effects in younger people and people who have bad lungs that actually have other conditions that are born out of vaping. I could imagine that there are chemical reactions or there are what we call carcinogenic reactions in the body that could potentially lead to lung cancer. But as far as I'm aware, there is no direct scientific evidence pointing vaping to lung cancer as of right now.
Okay.
Yeah.
I want to take the subject a little bit different, right? Because around me, there's a lot of people who are smokers. And it's really hard to tell someone, please stop smoking, and they always say, I'm healthy. Okay. So I want to get a little change here, and I'm not sure, I think this is a joint question that both of you can answer, is this. Someone has lung cancer, all right? What are the things they are going through? Are they gasping for breath? What is the journey of someone being treated for lung cancer like? What is it like?
Yeah, so maybe I'll answer first. So I think lung cancer as a disease is very heterogeneous. So we see patients with lung cancer from first thing is that we see patients with lung cancer from various stages, right? So stage 1, 2, 3, 4. And each patient's journey across each different stage is vastly different. The typical patient with early stage lung cancer, 1 or 2, would have gone for surgery, and typically after surgery they are cured. They may need a little bit of chemo, a little bit of radiation after the surgery on a case-by-case basis. But by and large, following that, the aim is for them to go back to normal lives. They can work, they can do whatever they want. For the patients with late-stage lung cancer, I guess a little bit more tricky. First things is that it does depend on what they present with and how badly the cancer has already affected them. And to be honest, many patients who are first diagnosed with lung cancer, they may not have many symptoms, even if it's stage 4. And the problem and one good and bad thing, I guess, but one thing about lung cancer is that it often remains asymptomatic in the body until such a time as it's big enough to cause problems, and which is also why screening for lung cancer is so hard to pin down, because patients don't feel anything, right, for the longest time, right? And when they come in with lung cancer, many times half of them are already stage 4. That's the sad part of it. But the flip side is that because the cancer doesn't cause many problems, and there are many patients who present even in the stage 4 setting with minimal symptoms, we can hopefully control it with effective treatments, and give them a very decent quality of life. My patients, many of my patients on oral tablets, many of them can even say go back to work, even on a part-time or maybe even a semi-full-time basis, because they are relatively well, even though they are on continuous treatment for lung cancer. But of course, we do get the patients who have a lot of symptoms, and the cancer has affected them, sadly, to a large degree. These patients can often be a little bit more debilitated, and they may need a certain level of care, whether at home or somewhere else. They may need help looking after their needs at home, all the while getting treatment for the lung cancer. Yeah, so it's very variable as to what you typically expect as a cancer patient. Unfortunately, it's not something that we have to individualize it to different patients.
I think the modern medicine, and with its advancement, with all the different therapy, it has become more, I would say, easier to treat, but there's a lot more options to treat, and that makes it more comfortable in that sense. But at the same time, for some of them, I've known a few of the cancer patients, especially lung cancer, they always feel very cheated because by the time it was being diagnosed, it's stage 4.
Yep.
They said, people go by stage 1, 2, 3, 4, they go to the adjournment. No, I'm being diagnosed. And they felt that when I heard stage 4 means this is like death sentence. And a lot of them started wallowing in that situation and felt very cheated. It's like, I didn't even go through the phases, I'm just pronounced stage 4 in that sense, and the treatment can be pretty harsh and aggressive just to make sure we curb the early stage symptoms and all.
That's right.
So I am a smoker and I have no symptoms. My doctor said my lung is very healthy. I've been smoking for the last 30, 40 years. So is there a correlation between smoker versus lung cancer? I mean, I know this is a very old question that we ask every year, but again, people are always challenging this fact.
So I think if you want to take something home today is that stop smoking as much as you can or reduce your smoking amounts. The longer you have stopped, as I've showed, as Dr. Tan has showed on his slides, the longer you stopped, the better your outcomes. There's also evidence, scientific evidence to show that even if you've been diagnosed with lung cancer, your overall outcomes from the treatment that we give you improves if you stop smoking because your response to treatment is also better. These are all proven. So if there's one thing you take home today is if you can cut the smoking and then stop as much as possible. That's really what I always tell my patients. Smoking is also related to all other cancers. Prostate, breast, colon. So please do stop smoking if you can.
Yeah, I think absolutely agree with that. So I think some of us would question because we all know the chronic smoker of 50, 60 years who may not have had lung cancer, right? But I think the important thing to appreciate here is that lung cancer is smoking is a risk factor now. It is a strong enough risk factor for us to say that smoking is a big cause of lung cancer. But of course, there are other factors which factor into this. So, for example, things like whether there's a familial predisposition. Some patients are just more apt to develop lung cancers than others. However, it is also important to note, as Dr. Vaish said, that smoking results in many other health problems other than lung cancer. All right. So by stopping smoking, you may even if you're not helping the risk of lung cancer, you are helping the risk of many other health issues. For example, other cancers, as well as even things like chronic lung problems, chronic heart problems, which can affect you very badly in time to come if you continue smoking. Yeah.
Okay. There's some questions that came in. One of the things is this, I feel I need to pull deep breath, although the person is not wheezing. In the health screening, the report says scarring, possibly due to past infection. All right. Now, scarring. What does this word mean? What are the things that the person needs to do? Is there any other follow-up checks that they need to continue to do that?
Yeah. So I think over the course of our lives, we are, even if we are non-smokers, we are often exposed to many different things in the environment, whether be it infections. So tuberculosis is one common one in Singapore, or any lung infections could do it. Or environmental allergens and stuff like that, which can cause what doctors typically put to you as chronic scarring in the lungs. And sometimes that can result in lung problems or problems breathing and stuff like that. My advice is that if you feel that the symptoms are bothering you, talk to your doctor. Right? Talk to your doctor. I believe that you may have in the course of a health screening, you may the screening agency may or may not have asked you to consult a doctor. A good place to start would be your neighborhood doctor, a GP or a polyclinic. If nothing else, even if this doesn't need any treatment, just to follow it up.
Yeah.
Follow up on your symptoms in case it worsens. You can catch it early, you can do tests early, and stuff like that. So definitely, I think consult a doctor, and a good place to start would be your family doctor. Yeah.
Coming back to it is that nowadays a lot of people do yearly body checks, right? So for someone that is a smoker versus a non-smoker, would you say that if I'm doing my yearly checks, I should do a chest X-ray versus the non-smoker? Maybe every 2 years I do a chest X-ray?
Okay, so as we've discussed slightly earlier, I think that's a great question, because I think the worry is that when we're smoking, then is this going to actually lead to more problems? And you're right, like what Dr. Tan actually said, the problems are not just lung cancer. You have, heart problems, cholesterol, all these things are associated with smoking. So part of the routine screening, and I think Singapore has fantastic screening programs. Just go to your family doctor, go to the polyclinic, just say that I'm here, I'm 50 years old, I want to start my yearly screening. Sometimes, depending on the kind of screening you have, if you go to a private doctor, you may have screening packages. So a chest X-ray specifically has not a lot of radiation, but the caveat to that is that if you were to do a chest X-ray, we don't know how much it can actually detect a lung cancer. And the studies that we have, the international studies that we have, that what Dr. Tan said, doesn't reflect our local population. Even if we were to use those studies to extrapolate to our Singapore setting, these studies were done with what we call CT scans, and they were specific types of CT scan called low-dose CT scans. So I'm not so sure how chest X-rays would be very helpful, but to again caveat that for the second time, many of our patients, I'm sure Dr. Tan will agree, have been picked up with a mass that was seen or a spot that was seen in the lung on a routine X-ray that was just done for COVID-19, follow-up, or a routine like pre-work employment check.
Yes.
And that's why we find it. If that's the case, then great. But the issue with that, the reason why our ministry cannot actually determine that X-ray should be done in everyone is, most importantly, are we doing too many X-rays which have radiation? There's all these things in people who are completely have no cancer, and our median age of survival in Singapore is 85, 86 years, in men and women. So that's why it's hard to implement chest X-rays. So we can't definitely say, but if you are a smoker, I think you should visit your family doctor or go and see a pulmonologist in the hospital to help you work through reducing your smoking, and also, if needed, put you on a follow-up program. And to answer about someone who has about scarring in the lungs, depending on the kind of scarring you actually have, if it's actually spots in the lungs and not just scar tissue, there are actually guidelines for pulmonologists to follow up the kind of spots in the lung, which are actually slightly different from scarring, but there are guidelines for certain things which we may not be routinely aware of. So it's good to actually refer back to your doctor instead of Googling yourself or like panicking, because it can be quite worrying when you see these kinds of things on your CT report, your X-ray report.
Yes. So coming back to that is this, with blood tests, right? Like CA125, 199, can the blood test also pick up lung cancer?
I think perhaps I'll take this. Short answer is no, there's no evidence. So if we look at MOH screening guidelines, the first thing is the question about X-ray. MOH actually doesn't recommend routine surveillance X-rays as a screening tool for lung cancer. All right, specifically for lung cancer, a doctor may do a chest X-ray for other reasons, of course, not just lung cancer, because a chest X-ray is good for many other lung conditions. But chest X-ray itself, specifically for lung cancer, has not really been shown to be such a good screening tool, right? So extending that to what you said, blood tests, right? We often we all have this experience where we go to a health screening and we're recommended to do a panel of tumor markers. The official stand on this, I must say, is that most tumor markers actually don't really have a defined role in screening for cancers, right? Okay, now that being said, if a tumor marker has been done for you and it's positive, okay, don't panic, don't panic, okay? I think the first thing to do would be to approach the screening agency that did the screening for you and ask them if they have any recommendations for this, maybe somewhat abnormal test. Now, not all raised tumor markers are due to cancer, okay? And that's why we don't do it we don't typically do it for screening, because if it's positive, it doesn't really tell us that it's cancer. It's not very helpful. But if you already have one done and it's positive, I think the first thing to do, again, I know we've said this multiple times, but do consult a medical practitioner and to advise you as to what's the next step. And the next step may be, in terms of monitoring, whether we should repeat the tumor marker to see whether it's really positive, because there can be false positives, false negatives, whether a referral on to appropriate specialist needs to be done to check for any potentially problematic health conditions, and so on and so forth. Yeah, so do get a medical consult if let's say this comes up. Yeah.
I think one of the things is this, if you've done a screening or you've seen a doctor asks for certain tests done, you need to understand what is the outcome. Do you need to, and I probably repeat myself like a broken record in every session, is this, you need to understand what happens next. Do I need to follow up? What does this mean? Do I, rest and take another test 2 years later, or I need to have follow-up treatments? You need to establish that relationship and ask those questions, because a lot of time we have people says, I don't know. But did you see the doctor? Yeah. Yeah, but I don't know. So you need to know, and you need to actually understand what happens next. Whether do you wait or you go back for the test again, or this is good, is something that you don't look at it after a few more years or whatsoever. You need to have that conclusion and make that decision. Jot down that time in the diary. Some people are very naturally very nervous. Then maybe you need to bring a family member or a very good friend with you. When you go for the results. Because there are people who only intermittently listen to things that they want to, like my mother does. So we go with her, so that she doesn't only hear the good things. The doctor says it's very good, but actually it's not true, So these are some of the things that we need to know ourselves and understand the conversation in order to follow up. So there's two questions that I picked up on the screen. One of them is that for people who was first time picked up with lung cancer and those that has relapsed, what is the general life expectancy? Number one. Number two is that, could you explain what are the mechanism on how the growth of a tumor interferes with the function? I suppose the tumor in the lung will interfere with the function of the body.
Yeah, so the question about general life expectancy. So I always tell my patients this, right? Life expectancy is a tricky thing, right? So the first thing you need to ask yourself is what stage the cancer is. And if your cancer is early stage or even locally advanced, i.e., stage 3 lung cancers, these cancers are often curable. We do the whole plethora of treatment, whether it be surgery, chemo, radiation, or etc., in an effort to rid you of the cancer totally, right? So now, of course, we always say all cancers have a risk of relapse. Right? Nothing in life is 100%. No treatment is 100%, even surgery. But if we are aiming to cure the cancer and you have cured the cancer and you don't recur, right? The life expectancy is, it's generally we take it to be equivalent as that of, a normal person without cancer, right? Right.
Yeah.
Now, however, if let's say we are dealing with relapse of a cancer, now this in itself is still tricky because it depends on where the cancer relapse in. Now, does it relapse in the lung? Is surgery still possible? Is radiotherapy still possible? Is curative treatment still possible? If it is, we do it, right? And again, by extension, if we go for curative treatment and you're cured, then the life expectancy is good, right? But the problem is when it recurs, and it recurs as a stage 4. It relapses as a stage 4 cancer. Now, unfortunately, stage 4 cancers, traditionally we can't cure stage 4 cancer. Most cases of stage 4 cancer, we have effective treatments, and these treatments are often able to control cancer for a prolonged period of time. Mm-hmm. Okay, but ultimately, we may see that the cancer may start growing again, in which case life expectancy may not be as good as what we term as the general population. However, that also depends on what are the treatment options available. And it also depends on how strong you are, and how strong you are. Again, a picture is also directly related to how much you've smoked, because how healthy is your heart, how healthy is your lungs, and how easy your cancer is to treat. These are all related to many things, and smoking being one of them. So again, it goes back to our original point, right? I think it's very important to quit smoking, whichever stage of the disease you are in. The second question.
The second question was that, how does lung cancer affect the mechanism, the body function?
Yeah. So it depends on where the lung cancer is. So if the lung cancer is only in the lungs, I think as Dr. Vaish has alluded to previously in the presentation, it can cause a multitude of symptoms. Could be cough, could be breathlessness, depending on where it is in the lungs. If it is in a very central part of the lung and it's compressing on the airways, for example, leading into the lungs, you may have a higher tendency to have some breathlessness. You can have mucus, you can have blood in the mucus and stuff like that as well. Sometimes lung cancers present with water in the lungs, what we term as an effusion. That can also sometimes cause breathlessness, chest discomfort, chest pain. If the lung cancer is in other parts of the body, for example, the brain, it may cause things like headaches, dizziness, balance problems. In the bone, it may cause bone pain. In the liver, it may cause jaundice. So there's really a plethora of different possible symptoms for lung cancer. And sometimes it's hard to pin down, but I think the biggest thing to look out for would probably be the lung symptoms. So the cough, especially if you've got blood in the mucus and everything, that's certainly a bit of an alarm sign that you should consult your doctor about.
So on the one hand, we have great treatments that, even at stage 4, they could give you target immunotherapy that ease the symptoms. But why take the chances, because you never know if the flip side was people who need breathing apparatus, they have heavy, difficult in breathing, maybe even hard in breathing, and you need to sleep in certain positions, because it's dangerous. You need to drain out the water, different types of things, So this is your chance. That means the chance is like, do I want to maybe go into the extreme? Well, I also know there's great medication. You never know because everyone's body is different. The treatment for everyone is also different. And sometimes, despite with a array of great advance of treatment, the person's body, due to it, may not be receptive to these treatments. And then it's like, I have all these things, but why can't I use it? And too bad, So why take the risk? So the first message is that quit smoking, reduce your smoking slowly, and work on that. Find something else to do, I know a lot of people who smoke. Previously, when I was smoking, it was just something to do, So I found something else to do, and so that's how it is. I think, again, this question keep coming up, right? So we're going to ask the last question is this. So there's always smokers that get screening, because if you go to the doctor, tell the doctor, I'm actually a smoker, the doctor, will send you for screening. For non-smoker, I guess you need to also set this, I'm actually a second-hand smoker. My husband smoked, my parents smoke. I live with a smoker. I work in an environment that everybody smoke. I think this is another thing that you need to let the doctor know. Not that I don't smoke, but actually everyone around you is smoking. So that's another part of it that when doing screening, you need to let them know, because like what the doctors have said, they are now screening for passive smoker too. And in order to get this, the epidemiology and the statistics on that. So, are you lower risk? Not necessary. We do have a great number of people who are passive smoker that have lung cancer. We also have people who are smokers, they don't have, but then their family who are passive smokers who have lung cancer. So with this, I want to say thank you to both Dr. Muthu and Dr. Tan.
Thank you.
For sharing your insights on lung cancer with us today. And let me see. Well, we have almost come to the end, but we always leave you nuggets, of offers. Number one is please fill up your feedback form. With your feedback, we can do better. And the other one is that Singapore Cancer Society provides screening services at no cost for eligible participants. So for more information of Singapore Cancer Society cancer screening initiatives and other programs, please visit the website of www.singaporecancersociety.org.sg or call 1-800-727-3333. Early detection saves lives, okay? And we hope you have a great morning. This is Saturday, and have a great weekend, everyone. COVID's not over. Wear your mask, sanitize your hands, and take care of yourself. I'm Ivy Lim with Dr. Muthu and Dr. Tan. We say have a great weekend. Thank you.